for joining us. We're really tickled by the turnout and how many of you decided to raise your hand for this. So happy to welcome you to Civic's inaugural Change Agent Chat. My name is Jay Want. I'm a general internist, and I'm Civic's Chief Medical Officer, and I'm really pleased to be joined by Jackie Brown, who's going to talk to us about Southeast Health Group's Tipping Point program in just a minute. But before we get started, just a few housekeeping things. The phone lines are currently muted, but you have access to a chat box, I think, on your screen, hopefully, where you can actually enter questions. We're going to do some of those at the end, but if they actually work in the flow of the conversation, we may kind of pull one or two of those out and do them in the course of the conversation. This webinar is being recorded, and if you have friends who missed this and want to see it, later on it'll be available on the Civic website, again at any time without any cost. So just to introduce today's chat, smart person, some people say Einstein, but it probably wasn't Einstein, said the definition of insanity is doing the same thing over and over again and expecting a different result. In the case of American healthcare, that means that unless we actually change things, we get to keep spending twice as much as the rest of the industrialized world and getting worse results despite that. So I'm convinced that we can do better and that different and better ways really are less and less likely, for reasons that we can talk about in another chat, to come from some central plan. It's not going to be our central plan. It's not going to be Washington's central plan. I don't think it's going to be anybody's central plan. Instead, I think that innovation in the 21st century probably is going to come from the local level, and in particular from communities where people find ways to work with one another. And indeed, when we at Civic have looked over the past several years, we've found many Colorado examples. With limited resources, these change agents are starting to deliver on the promise of the AAA: lower cost, better population health, and better patient experience. And we're excited to bring these people to our stage, so we might all get a little bit smarter together. So today we are privileged, really, to be speaking with Jackie Brown, who is the Integrated Care Director at Southeast Health Group in Lamar, Colorado. We were talking just before the chat. She originally is from Northwest Colorado, but has ended up in Southeast Colorado for looks like almost 30 years at this point. She's been with Southeast Health Group for 5 years and was the director of the Prowers County Public Health and Environment Department for 22 years prior to that. In 2012, Southeast Health Group, in what I remember as a very competitive request for proposals, won a 3-year, $1.4 million award from CMMI, the Center for Medicare and Medicaid Innovation, to develop an integrated care program called Tipping Point. And that's actually an acronym which stands for Total Integration, Patient Navigation, and Provider Training Project. And as Integrated Care Director, Jackie has worked in this program to engage primary care providers as well as local communities and the resources to identify those things that are needed to implement initiatives designed to enhance health outcomes and service delivery and address service delivery inequities on the Eastern Plain. So without further ado, Jackie, it's great to have you with us today. So all that sounded really great, but can you tell us exactly the guts of this thing? How does this actually work down in Southeast Colorado?
Well, I'll start back at the beginning. When we had the vision, Southeast Health Group had looked at how we might move into a new area. You know, we've been a traditional community mental health center, but we just knew that we had to look bigger and broader and think about a little bit outside the box. So when the project was developed, it was developed with the idea that we would create a training program and work with Otero Junior College to develop a navigator program to basically infiltrate the systems, the healthcare systems. And in our first class, we had about 24 people, I believe, that went through the curriculum. It was a 3-month curriculum to get us off the ground. And we had participants from the community health center, the hospital, public health, and our 6 navigators that we hired to help us integrate and use navigators on our program. And basically, the navigators were given carte blanche. They were able to do about anything that we needed to do for the patients that we were serving. You know, with the premise basically that we were going to teach people to self-navigate the healthcare system and self-manage their chronic diseases. And one of the things that we knew when we were looking at putting this together was that nationally 50% of the Medicaid funds were used by about 5% of the Medicaid population. In Pryor County, 61% of the Medicaid funds were used by about 3.7% of the Medicaid members. And we have small numbers, so it was about 133 people. And we were able to track and follow 108 of those people. But the navigators worked within the team. At the same time, we developed our integrated healthcare program, added primary care provider, and in our La Junta office, and we basically just reformatted how we were going to work with people and how we were going to work as a team to care for people. One of the things we did right off the bat was to develop a clinical meeting that we had every Monday at 2 o'clock to discuss problem patients and strategize. And it was a large team, navigators, case managers, health coaches, myself, the healthcare providers, the COO, and some other key people. So we just got in and we just decided that there wasn't anything that was impossible, that we were going to look at every opportunity and not look at it as an obstacle. So we just decided we were going to do it, and that's not saying that everything went perfect, but that's how we started the program.
So when you started, you used the term infiltrate, which sounds kind of subversive to me. It sounds like you actually had to kind of break into the system in some way. Can you talk a little bit about that? That's a very small population using a lot of resources, which implies to me the system wasn't really working for those people. Is that right?
Well, what it was that people didn't know what a Health Navigator was. I can't tell you how many presentations I did and how many people that even worked within the healthcare system they said, well, I don't understand. What does a Health Navigator do? How do we use them? And we used the Health Navigator models that had been developed in the 90s, and there's been a movement, and we also used the hot spotting information from Dr. Brunner, and it took a lot of education and to get people to see that it wasn't just one more thing, that it was really an opportunity to take these very high-cost patients and look at them holistically rather than a collection of issues that oftentimes fell through the crack. And a lot of the patients were our patients. And so for us, we felt like that to be able to provide good integrated health care, we had to be able to have a team approach, and that included the Health Navigators. But it took some time. I will be honest. People were just like, well, when we invited people to attend the classes, we were asked, well, now what will this do, and how will we use them, and so we kind of had to teach everybody or collaborate and talk about ways that they could be used throughout the system.
So take me through that a little bit.
And it didn't take long. We really, I think people now are pretty sold on the whole idea.
So take me through this, Jackie. Let's imagine that I have signed up for the class at Otero. What am I going to learn? Because what you just described is, listen, we have all this complexity. Just do whatever's going to work for this patient. I'm trying to imagine a curriculum, but it's kind of hard for me to imagine what you'd be teaching me.
Well, I will tell you, we have a great program at OJC, and they took the ball and ran with it. We got them started and gave funding to the program, and they have a great coordinator, Casey Schmidt, and they can actually get a certificate for 1 year, and then they can get a 2-year degree. So they have a couple options. Example of classes in the first year, which is 32 credits for the health worker certificate, is community health work, community health issues, community health resources, English Comp, Intro to PC Applications, CPR for Healthcare Professionals. In the second semester, they go on to Basics of Chronic Disease, Psych Impact of Chronic Disease, End-of-Life Palliative Care, Patient Navigation, General Psychology, Interpersonal Communications, Medical Terminology, and Motivational Interviewing. In the third semester, they do field experience, and that's the other great thing that we've been able to do. We have, I think, around 30 placements for our navigators that are attending the program at OJC, and they do an online program as well. But they're able to get partners that really want the students to come there to do their clinicals. And then they go on, if they want to go on and get a 2-year degree, then they just layer on that, the higher levels of each one of those topics. And then they've also been working with some 4-year programs to create kind of a ladder concept, kind of like nursing does. So there's some opportunity there too. But they also do classes at Fort Lyon for the Colorado Coalition for the Homeless, so that they can include some of their residents in the program. But it's a great program, and for more information, I just go to Otero Junior College website, and you can get anything. They've got a brochure on there, and there's contact information. Great program. They've been recognized, and Casey's done a lot of presentations nationally on their program.
So I have to ask, because I'm a physician, what was the reaction of the medical profession to all this? I mean, because you named a lot of stuff. A lot of it's very interesting, but I can imagine somebody saying, "Wait a minute, I didn't hear basic biochemistry and pharmacology and microbiology in that curriculum. I'm not really sure how these navigators can actually help my patients." Did you get anything like that?
Well, I think they're, what you find a lot of times, and this is, not against doctors, but doctors are kind of set in their ways sometimes, and they've been used to doing it all, and they've never had, I haven't had any help before, and
right.
but they're frustrated because they need help. But I would say now, after they've been able to use the navigators, they love the navigators because they've been able to work with the navigators to make sure that these complex patients with all of these issues get the care that they need, and that they understand, they're really a conduit, and they work really closely with the docs. And I would say now, here we are down the road 5 years, and our program is pretty ingrained within the communities that we serve. I mean, I think the doctors appreciate the care, and I think they look to us to assist them. And and they could probably tell you narratives of patients that we've helped, and they've been glad to have us on board. But it's it's like anything, when you're making a change, people struggle sometimes with that, and it doesn't matter who you are, and until you see a success, sometimes you're not too excited about change.
But so how do they react to the success? Because I've actually worked in another program on the East Coast where same kind of thing, offering more resources and all that, and pretty much there was one of these at the door for months, sometimes years, basically, for these docs. But then when they see a success, their attitude changes. Can you talk a little bit about that?
Yeah, what happened, and what I've seen happen, is that the resistance was there at first, and you couldn't, you would almost struggle getting them to even come to the table and access the patient navigator. And it really took actual events that happened and helped us get them to agree to be part of the system. And what I see now is within our own system, our providers come to our clinical meetings, and they bring with them, they'll talk about things that have happened, or ways that the navigators have helped, and and then for those that are more difficult, we come together, even with the providers at the table, and say, okay, you know, we've done all this and this isn't working, and the providers are just as much a part of that team, and look to the navigators and look to the other team members to provide guidance to them too. And I just think that if you ask the providers now, they would tell you that it's been a great resource to the patients that we serve down here in Southeast Colorado.
So let's imagine that I was one of those providers in Lamar. I was skeptical at the beginning. 5 years later, I'm a true believer. What am I able to do with my team today that I wasn't able to do 5 years ago?
Well, you're able to make sure that that patient who you saw for 10 minutes and you told them to do 10 things, and then you don't know whether they got the 10 things done or not, or if they even understood the 10 things, that patient now has a health navigator that is working with them to help them accomplish those 10 things, you know, whether it's seeing a specialist in Denver or going to a class on diabetes or finding, you know, sometimes the provider doesn't even know what all the things that the patient is dealing with. They're maybe homeless, they're maybe, you know, struggling with mental health issues that they've not, you know, come out with. And so the care provider, the doctor, the PA, the nurse practitioner, basically hands, you know, the patient off with the understanding that the navigator is going to help that patient accomplish the things that need to happen. And, you know, it's always interesting to me that, you know, that we expect patients to come in, especially patients that, you know, are already struggling, and that how are they going to figure out the healthcare system? Heck, I sometimes have problems with the healthcare system. And so I think that it's a win for the healthcare provider because they feel like they finally have the help and the team that's going to make sure that that complex patient gets the things done, you know, the medicines, the trip to the specialist, the, you know, come back to the doctor or to communicate what I've told to that patient.
In one of the prep materials, I read that transportation is surprising, at least to me, one of the most successful parts of the program. Now, as a doctor, I don't think I've ever written a prescription for drive this patient to the specialist in Denver. Tell me how that worked, or why that was so effective.
Well, and that's the problem. I worked in public health for many years before I came here, and I can tell you that that's the breakdown. You know, doctors will tell them, well, you know, you need to go see this, you need to go have this done in Denver, but then they never figure out or know that the patient doesn't have a clue how they're going to get there, or let alone, you know, have the transportation to get there. And in rural Colorado and southeast Colorado, we have very high poverty rates, very high chronic disease rates, and transportation and the lack of transportation is always identified in every community assessment as an issue. And because we don't have a lot of specialists, you know, a specialist may come here and they may see them, but then they'll want them to come and do their testing or whatever specialty test, or even minor procedures or even major procedures in the urban Front Range area. And so it's really imperative for people to have a way to get there for care. And that has been one of our biggest pieces of the patient navigation program and the health navigation, is that to be able to provide transportation to our patients that need to go to another place for care. I mean, it's about 219 miles to Denver from Lamar, and you know, we don't have public transportation that takes people there. So I mean, it's a big need, and it's a big problem, and it takes a lot of coordination. But that's really been a failure for many years in the healthcare system. Is, you know, they may tell them to go, but how they're going to get there is another matter.
Reminder to the audience that we'll be opening up here for questions in just a couple minutes. So if you have anything, you can type it in the chat box, or can we actually take them by voice, Steph, or just by chat? Okay. So if you enter any questions you have in the chat. So I know the answer to this question, but I'm going to ask it so that you can give the answer. How many miles have your navigators driven over the past 5 years?
Oh, I don't know exactly how many, but I know that it's a lot. In the 14-15 year, I think it was almost 500,000 miles. But it's a lot of miles every year.
That's very cool. So this is great work. This is obviously wonderful work, but this is the pattern that I have oftentimes seen in grant-driven activities: is that great idea, grant funds the work for a limited period of time, and then when the grant goes away, the program goes away. Your program's different in that you're past the 3 years with CMMI at this point, and you're still going strong at this point. How does that actually work?
Well, you're right, and I've seen that myself over the years, and and when we went into it, we weren't exactly sure either. We really wanted to see how it worked and if it worked, and we kept our data, and we knew we were being successful. I mean, we could tell as we got into it more and more that it was effective. It reduced cost. We kept logs of narratives, of stories about people that we had served and what had happened with them. And so we knew that as we got towards, we were in about our last year, that the management team and the project team and some of our other staff, we just knew that it was so important that we had to figure out a way to keep it going. We knew that there were some things we wanted to change, because you kind of figure out, too, what works, what doesn't work. And so we looked at ways to fund it, and we went from 6 health navigators to 4 health navigators, and then we repositioned them a little, and then we added peers about at that time, too. And excuse me. And when we added the peers, the peers actually took over the transportation piece, so we were able to, which has been really effective. But what we did is we took our funding. We're part of a regional care collaborative, and we used some of our funding to continue that. We also got a grant from CIVHC to do the diabetes.
Getting a lot of questions in the chat box about the financing. It sounds like there is some, because it benefits the state ultimately, that you've got some grants basically to kind of try to continue the work, and some of the transportation function has been taken over by unpaid volunteers. Is that right?
No, the peers are paid. We pay the peers. They actually work for us, and we have a large peer program. And we started the peer program in the same, about the same time, in about the last year of our project. And we have a huge peer program, but they are paid, and they are great. We have a great peer system, and that's actually worked really well because the patients love it. They love the peers, and they love working with the peers, and that's been a great way for us to use the health navigators then for the more complex, the more difficult work of being a health navigator. But they work as a team, and the peers and the navigators and the integrated healthcare team all work together. And we, like I said, we meet weekly and discuss strategies and problems and issues, and we really, we don't see the problems as things that we can't tackle together.
So I'm going to, we have about 5 or 6 minutes left. I'm going to try to blow through some of the chat questions because I promised them that we would try to answer some of them. So Dana Brass asks, Jackie, what kind of technology are you using to track all the services needed and then provided? I mean,
well, we have Yeah, we have a great data system. We switched over to Avatar from Profiler last year, and so we use Avatar that tracks all of our patient services. We have a great chief data person who is a guru at tracking all of the financial pieces, the numbers, the information from Avatar, and that is a partnership. We're involved in a collective group of community mental health centers through CIVHC that enables us to have some really great tools to manage our numbers and evaluate what we're doing.
That's awesome. Marty Coleman asks, how do your navigators support care collaboration between primary care and behavioral health and between specialty and primary care?
That's a great question because that's really been a strong piece of what we do. If somebody comes into primary care and they've not been into the behavioral health side, and the primary care folks determine that we need to integrate and get them warm handoff to the behavioral health, or they decide that they need to have patient navigator services, they bring them in at the time of the visit. We get them hooked up, and they'll do intake with them and begin the process. The providers determine or tell us, this is what I'm seeing and this is what I think they need. Can you meet more with them and figure out what we can do for them? And so it's a real team approach, and it's a warm handoff kind of a process. Very
cool. Patricia Cook asks, are more seniors or the families now utilizing smartphones, internet, social media? I mean, are any of those kind of part of your program, or is this more traditional kind of face-to-face?
Well, it's a lot of face-to-face. We do use smartphones. A lot of the folks down here do have cell phones or smartphones. We don't do so much on the internet. I mean, some do, some don't, but that's kind of, you just never know. But we do use the cell phones to communicate, if we need to confirm appointments with them or to confirm the travel or, whatever we need to do. And we do go to their homes. I mean, we actually go to their homes if need be. We really make every effort to keep that communication going.
Great. There we go. Cassandra Rogers, says, have practices in Southeast Colorado welcomed or onboarded Health Navigators onto their staff? I mean, essentially, do the Health Navigators become part of the practices teams in some way, or do they partner with Southeast Health Group to bring on navigators? I mean, basically,
we do have some that have their own navigators, but we also partner with, like here in Lamar, we have a navigator at Pryor's Medical Center that works with the staff and doctors and providers at Pryor's Medical Center. We have a navigator that works in Rocky Ford at Doug Miller's, I think it's Doug Miller's office, who has a clinic up there. We've had navigators in some other places at times, and sometimes it doesn't always work out, but then a lot of the places will also then get their own navigators. So we've seen some of that too.
So it doesn't matter to you guys. I mean, they can be employees of the provider, or they can be yours, but you work generally the same way, irrespective of who cuts their check. Is that right?
Well, I have seen some nuances and differences, and I think the nice thing is that if you're going to use a health navigator, you can self-design, within your own system how you want that navigator to play a role. And I think for us, we've made it fit our needs and our services, and have partnered with some others that we've been able to do the same thing with. But, our hope is that with the OJC program, that you'll see Health Navigators be in every healthcare facility, whether it's public health or, a rural clinic, a FQHC, a hospital. I think that Health Navigators can lessen the load and reduce the cost, and we can have better outcomes, and I think patient satisfaction goes up. So, I would like to see them be part of the healthcare team in every system, every opportunity.
Very cool. Boy, I could spend another couple hours actually talking to you about this, but I just want to thank you so much. It's a wonderful work, and we're really grateful that you raised your hand to be the guinea pig for the first one of these. Also, thanks to everybody who showed up on the phones and on the webinar. For those, if you have friends who missed this and might want to listen to it, the recording of the discussion, a brief summary, and a couple of patient stories actually that we didn't have time to get to will be shared via social media and on the Civic website on Monday. Until then, please join us on March, actually it should be 24th, I think, when we chat with Christy Whitney, my friend from the Western Slope, who's president and CEO of Hope West, who runs the hospice on that side of the mountains. Until then, thanks everybody for joining us. Thank you, Jackie, and here's to your health and the health of the state of Colorado. Thanks a lot.
Thanks.